Good afternoon again, and welcome to the LAN's webinar, Accountable Healthcare Outcomes from the Field. As a reminder, this event is being recorded. We will now start the event by welcoming Judy Zerzan-Thole from the Washington State Healthcare Authority. Thank you, Judy, and welcome.
Thanks, Jonathan. Good afternoon, everyone, and I'm excited to help start Healthcare Value Week with this panel that I think is going to be very exciting and some good learning. So I'm Judy Zerzan-Thole. I'm the Chief Medical Officer at the Washington State Healthcare Authority, and I'm also the co-chair of the LAN's Executive Forum. The Healthcare Payment Learning and Action Network, or LAN, is an active group of public and private healthcare leaders dedicated to providing thought leadership, strategic direction, and ongoing support to accelerate our system's adoption of alternative payment models. Since 2015, the LAN has mobilized payers, providers, purchasers, patients, product manufacturers, and policymakers in a shared mission to lower care costs, improve patient experience and outcomes, reduce barriers to APM participation, and promote shared accountability. The LAN's goal is to increase the percentage of U.S. healthcare payments tied to value and quality through the adoption of alternative payment models, or APMs. We know that our healthcare system faces many challenges today: rising costs, poor outcomes, lack of accessibility, affordability, and effectiveness. These challenges can be addressed by changing the way we pay for healthcare and placing greater emphasis on alternative payment models and value-based care. We need to think about new ways to pay for healthcare that aren't just about the usual fee-for-service model. Just lowering the cost of care via payment reform is not enough. We also need to focus on accountable care. What, you may ask, is accountable care? Accountable care centers on the patient and aligns their care team to support shared decision-making and help realize the best achievable outcomes for all through equitable, comprehensive, high-quality, affordable, and longitudinal care. Last year, the Centers for Medicare and Medicaid Services, CMS, set a goal to have all Medicare beneficiaries and the vast majority of Medicaid beneficiaries in an accountable relationship by 2030. Most people in the healthcare industry agree that we should change the way we pay for healthcare to focus on the value it provides to patients and caregivers, not just the volume of services. The traditional way of paying for healthcare, which is called fee-for-service, incentivizes providers to produce revenue by increasing the amount of services they provide. This can lead to unnecessary and sometimes even harmful care. If we pay for the value of care instead of the amount of care, providers would be encouraged to engage in valuable activities like care coordination, which might otherwise not be compensated under a fee-for-service model. Through value-based or accountable care models, patients benefit from a care delivery system that focuses on patient needs and goals. Using alternative payment models, or APMs, to pay for value over volume of care can help providers focus more on patient needs and goals and ultimately transform the way care is delivered. So today, in a moment, we'll hear about the progress that has been made to date in advancing APMs in the marketplace. Then we'll hear from a panel of 4 healthcare leaders who will share with us their stories of the impact they've seen from APMs across the country. And specifically, we'll talk about how APMs are making a positive difference in people's lives. So to start off with, Andrea, I'm going to turn it over to you.
Thank you, Judy. And hi, everyone. My name is Andrea Caballero, and I'm delighted to be with you today. Every year, the LAN assesses the extent to which APMs, or as alternative payment models, as Judy has said, we measure the adoption of APMs through a national evaluation of health plans, Medicaid states, state agencies, and traditional Medicare. We work with CMS, we work with AHIP, the Blue Cross Blue Shield Association, and other state Medicaid agencies. And all of those will be represented today on our panel shortly. You'll hear from them. They send us the data and we aggregated for the national results that you'll see here. These groups report on the total dollars paid to providers in the commercial market, Medicare Advantage, Medicaid, and the traditional Medicare markets. And the results of all of this represents almost 264 million, or 86.7% of people covered by an insurance plan in one of those markets, commercial, Medicare Advantage, Medicaid, or traditional Medicare. And through this effort, we're able to measure the extent of APM adoption across the nation. As I mentioned, we've consistently been measuring APM adoption according to a framework, and this has been since 2015. And this is a nationally accepted method, and it's a way for us to standardize and measure the progress toward APM adoption. The continuum you see here, the framework you see here, shows what starts as a continuum on fee-for-service, moving to more financial risk between health plans and providers and their contractual arrangements. Payment models in category 1 on the left in the orange column utilize traditional fee-for-service payments, meaning that there is no link to quality. And as you move to the right in the red column, you have category 2. These are still based on fee-for-service, but there is some link to quality. So you can think about these as pay-for-performance or the care coordination payments that Judy referenced. As we move to the purple column, we have payment models in category 3. These are still built on a fee-for-service architecture, but these models in this category hold providers financially accountable for performance on quality measures. You can think about these as shared savings models or shared risk models, and even a little bundled payment. The difference between 3A and 3B in column purple here is that 3A is that there is an upside financial reward for providers, and when you move into category 3B, there is financial downside risk. Finally, in the green column, we have category 4, and the payments in this column represent prospective population-based payments. They're structured in a manner that encourages providers to deliver well-coordinated, high-quality, person-centered care. So as we measure each year according to the framework, we also have goals for each of the market segments that I mentioned. The LAN is interested in accelerating the percentage of U.S. payments that are tied to quality value. And we have goals set for each of the market segments here to reach APM adoption in categories 3B and 4 by 2030. So now let's quickly look at the results from our 2023 measurement effort. This is looking back on 2022 data. We have a look back measurement period here. So all of this information you can see on the left-hand side here, you have all lines of business. This is a combination of commercial, Medicare Advantage, traditional, and Medicare and Medicaid. In the all lines of business column, we are seeing significant gains in the percent of APM payments that are shown in categories 3B and 4. This is the dark purple and the green. These are two-sided APMs. And in our most recent data year, 2022, nearly a quarter of all healthcare payments were considered a part of two-sided risk APMs across all lines of business. And this is a 5 percentage point increase from the prior year's data. That's 2021 data. All lines of business, when you look at the other columns here, saw significant gains in downside risk. That again is that dark purple and green parts of the cylinder. The commercial market saw a 4 percentage point increase year over year, and it's been its largest increase since the LAN started tracking APM data. The Medicare Advantage market has the largest percentage of APM payments in downside risk arrangements. It's currently at 38.9%, and this is a 3.7 percentage point increase over the prior year. Traditional Medicare has 30.2% of APMs in downside risk arrangements, And this is a 6.2 percentage point increase from the prior year. This is the largest increase in downside risk of all of the lines of business. And finally, looking at Medicaid, Medicaid has 18.7% of APMs in downside risk arrangements, which is about a 2 percentage point increase from last year. Every line of business saw the most growth in categories 3B, the shared risk arrangements. For the first time in 2023, the LAN also measured the number of covered lives that are in accountable care arrangements. And in Judy's opening remarks, we heard a little bit about what the LAN's definition is about accountable care. So for the purposes of measuring the lives in accountable care arrangements, it must have two elements. The first is that the care has to be at least 6 months or longer. It has a longitudinal nature to it. The second element is that the payment model must incorporate accountability for total cost of care. So for the first time, we were able to measure this. And in 2022, over 1/3 of lives are in accountable care arrangements across all lines of business. This is 36.1%. Each person icon on the screen represents 5 million lives. So that means there are over 93.1 million lives in accountable care arrangements in all lines of business. So overall, we've learned that the number of healthcare dollars being paid through two-sided risk arrangements and alternative payment models is increasing. And we've also learned that over 1/3 of lives are covered through accountable care arrangements. If you're interested in more details about the results from 2023 LAN results, you can find them on the LAN's website, in our methodology report, and in an interactive infographic. Thank you. Back to you, Judy.
Thanks, Andrea. So I'm pleased to be joined today by an amazing panel of leaders from across the healthcare industry. Today, we're joined by Purva Rawal, Chief Strategy Officer of the CMS Innovation Center, Danielle Lloyd, Senior Vice President for Private Market Innovations and Quality Initiatives at AHIP, Jennifer Nowak, Executive Director for Network Portfolio Commercial Markets at the Blue Cross Blue Shield Association, and Emily Brower, Senior Vice President for Clinical Integration and Physician Services for Trinity Health. So far today, to kick this off, we've heard that alternative payment models, or APMs, is incentivizing paying for value instead of volume. We've also learned there's a general trend towards using APMs. During today's panel, I'd like to hear from each of you about how APMs work in action and talk about some of the success stories you've seen from putting APMs into your work. Specifically, we'd like to talk about how your work and the work of your members is making a difference in people's healthcare and people's lives. We're going to open up the panel for all of you in the audience to answer some questions in about 25 minutes, and we welcome you to ask us anything and everything. So put them in the Q&A at the bottom of your screen at any time through the panel. And once we've had some discussion with each other, we'll get to those questions. So I'm going to start with Danielle. Danielle, AHIP is a national association whose members provide healthcare coverage to hundreds of millions of Americans every day. And many of the payers who are member organizations take part in value-based care arrangements. Can you talk to us about some of the outcomes you've seen for these arrangements, and specifically what have been some of the impacts for our patients?
Yeah, sure, happy to. And thanks so much for the LAN for inviting me to share some of the great work that our health insurance providers are doing every day in the area of value-based care. Of course, they're the ones doing the heavy lift. Certainly AHIP helps out, but I want to give them due credit since we're sharing their work. I also want to hammer home something that Andrea was talking about. Value-based care is not a pilot anymore. It's not an outlier, right? The Medicare Advantage plans have nearly 60% of their payments going through these models. The number's a little different than Andrea's because hers was just the risk base, but in totality, right, it's 60%. and the commercial have about 35%. So this is really to the point where it's becoming the new normal. So that it's not just many plans, it's most plans. And so what does this mean, these programs for our enrollees? It means that they are seeing improved quality, equity, experience, and affordability of care. And by the way, there is also a goal as we're going through these programs and setting them up to actually reduce administrative burden on our physician partners. So going through a couple of those, if you think about, for example, higher screenings, everybody loves to get their colonoscopies and their mammographies, right? But sometimes you need a little bit of prodding from your healthcare providers to make sure you get those done, as well as fewer hospital visits. Nobody wants to be in the hospital. So giving some example on those, Humana, one of our members, reports screenings are 3 to 11% higher as part of their value-based programs, and that there are 30% fewer hospital admissions in these value-based programs. Another example for Anthem, they have an arrangement with a partner named Validate, and their work together has resulted in increasing the hemoglobin A1C testing for diabetics by 10%. And that enabled them to reach 9 out of 10 eligible patients, which, it's helping them get to those really last sort of hard to reach parts of their populations. A last example I'll give in this bucket is for Florida Blue. Because this one is a hospital, a pediatric model. It is a hospital model, but in particular, it's a pediatric model. And in addition to seeing lower costs, they also simultaneously saw increases in their preventative services, like we were talking about. So an increase of 15.7%, decreased readmissions to the hospital by 24%. There's other beneficial effects. There's improvements in the patient experience. And I don't mean fluffy pillows. I mean, if a patient doesn't understand the instructions from their physicians, it can lead to poor outcomes, things like that. But there are actual increases in the patient experience in these programs. And certainly we don't like to lead with this, but there are cost savings, and that's important because it keeps care affordable for our enrollees. So an example there for Highmark, they have a program with nursing homes and home health that resulted in $12 million in avoided costs over 2 years. Providence, it's a West Coast integrated delivery network. They have a maternal health model that when you compared sort of like groups of patients, with similar profiles, if you will, that resulted in 15% lower costs. So there's some really great things happening that aren't just, some of it might be magic behind the curtain, but they're real impacts for patients.
Thanks. Those are some great examples. Are any of AHIP's member organizations engaging in accountable care arrangements with providers in rural areas?
Sure. Maybe to start there are some unique challenges in rural areas that might not, just come to mind for people who don't work on this every day. One example, to explain is, I sort of call it the math problem. Anytime you have small numbers, it can lead to really variable results. If anybody's on the phone, I'm going up and down like a wave, but so that you have to figure out ways to combat that. There's also more workforce issues. I mean, certainly things like behavioral health, their workforce issues are, sort of across the country, but, some of these things are more acute in rural areas. And there are also some difficulties, for example, with technology. So a lack of broadband access can impede use of telehealth. So these are things that, the plans need to kind of build into and think about in these programs. And AmeriHealth Caritas and Northeast plan, they really seek to collaborate with providers who are not typically in value-based programs, and really try to tailor the programs to fit their needs and the local needs of the community. And so they have a program called the small provider and rural communities, or SPARK program, that focuses on financial stability and that component of reducing administrative burden that I talked about. But so there are strategies on how to, for example, aggregate performance metrics so that they can overcome those low numbers challenges, and partnering with local teams to work with rural alliances to kind of get everything up and running, and use the community and available options. And then they also work on what we call upside models. So models where you don't have direct financial risk. That doesn't mean you don't have financial risk, because anytime you try to go into a whole new business model, there's of course financial risk, but it's not built into the system. It sort of starts them with this so-called upside only, and moves them more gradually into bigger risk-bearing programs when they're ready. But this really enables them to do work like with small physician groups that have panels of less than 50 members, close care gaps. So no, you haven't gotten your mammography, or you haven't gotten your colonoscopy, right? Working with the providers to do make sure that those sorts of services get done, and provide information on quality to make sure that the outcomes are improving, and that they're able to bring in community-based partners and organizations like food banks and others to, again, use those rich resources in the area to help fill in some of the gaps in these areas.
Thanks, Danielle. Jennifer, I'm going to move to you next. Can you provide us an example of how some of your member organizations are helping patients by advancing health equity through alternative payment models? And I'm thinking of some of the cool things that I know Blue Cross Blue Shield of Massachusetts are doing. So fire away.
Thank you, Judy, for asking that question, and thank you for the LAN for inviting me and a representative from the Blue Plans to sit on this panel. Before I talk about the great things Blue Cross Blue Shield Massachusetts is doing, just for context, I'm from an association, 33 individually owned and operated Blue BCBS or Blue Cross Blue Shield companies. These companies are community-based. And so we at the association are able to kind of participate in this unique structure of the Blue system in being able to derive and really coalesce around national initiatives where there needs to be a national effort and it's nationally, important. At the same time, each of our individual community-based Blue Cross Blue Shield companies can implement some of those initiatives in ways that make the most sense for their communities. We know in the United States, every community looks a little bit different, and it looks very different region by region, and healthcare is delivered very differently region by region. So just sort of setting that stage, I wanted to talk a little bit about what we are doing at a system level before I dive into the great work some of our Blue Plans are doing. One system level effort that's related to advancing health equity through alternative payment models is a focus on improving the standardization and the quality of the data that's necessary to both measure quality generally, but now we're needing to measure quality and stratify by race and ethnicity, and that is just adding that extra layer of challenge. We can't do that without standardized good data. So that's one thing we're focusing on as a system. Another thing that we're focusing on as a system to address health equity that's related to alternative payment models is really, targeting the inequities in maternal health care. And that's not what this call is about, but I think everybody has seen the headlines and, some of the inequities that are happening across our country today. So Blue Cross Blue Shield Massachusetts is a great example of just one of our Blue Plans. Many of our Blue Plans have efforts to address health equities, who are putting kind of initiatives in place, leveraging their longstanding value-based partnerships with providers in Massachusetts. Blue Cross Blue Shield Massachusetts has had the alternative quality contracts in place for over a decade, well over a decade. where they have incentivized the providers and health systems in their we call it service area or Massachusetts, to improve quality and to control the rising healthcare costs. So Blue Cross Blue Shield of Massachusetts is now including incentives based on measures that are stratified by race and ethnicity. Initially, this is only going to be a handful of measures, but over time, those measures will grow, and the stratification and the incentives based on performance by race and ethnicity will kind of grow as those measures, including the contracts, grow. But I do want to highlight that's not where Blue Cross Blue Shield Massachusetts is stopping when it comes to quality, health equity and quality measurement and transparency. On their public website, they publish the results for over 50 quality and experience measures, all stratified by race. This is if you're interested, it's a great place, a great website to visit to really understand kind of the impacts of race on the results that we see in some of the quality measures that are pretty standardly seen in our contracts. But tying it back to our system-wide effort, one of the measures you'll see on that website is the severe maternal mortality or severe maternal morbidity measure, and the results stratified by race. Pretty interesting, and I would recommend you do a quick Google search and check it out.
Great, thank you. Purva, we know CMS has set a goal of having 100% of original Medicare beneficiaries and the vast majority of Medicaid beneficiaries in accountable relationships by 2030. How do patients benefit from receiving care through a value-based or accountable relationship? And maybe you can toss in an example from some of the innovation center models, which I think really nicely show some of that impact.
Yeah, absolutely. First, let me just say thank you to you, Judy, for moderating today's event, and to the LAN for helping kick off Value Week. We all know the LAN provides a really important forum for advancing better healthcare, quality outcomes, and at lower costs. And there are events throughout Value Week, and I hope all of you can join more of these discussions over the course of the week. One of our main goals right now is to accelerate the movement towards value-based care. We need value-based care to build a person-centered health system more than ever. And we know that fee-for-service payment systems are not well designed to meet the needs of a patient in a holistic way. And those are some of the examples that I'll share with you. I've had the privilege of visiting some of our model participants over the last few years, some of our ACO models, our kidney models, and others. And I really have seen firsthand how our value-based care models help deliver better outcomes, care experience, and can lower costs. Some of the ways that we can do this through our models is helping address some of the challenges that providers are facing. So in some of the things we can do in our models, we can offer upfront investments for infrastructure and data that can help providers identify some of the patients that might be highest need or most likely to be hospitalized or readmitted. We can offer regulatory flexibilities that let providers care for patients in a home setting, for instance. We can provide tools and data to better coordinate primary and specialty care, for instance. And we can provide payment innovations or test payment innovations that truly give more stable and predictable payments to providers. We have also found that value-based care models can also help providers focus more on patients that need more attention. They can provide better care coordination and provide more patient-centered care, including assessing, for instance, people's health-related social needs. So I'll share two examples with you. The first is from our primary care first model. The primary care first model helped a Pennsylvania primary care practice add a full-time social worker to help address their patients' non-medical needs. One of their patients, a retired florist, found his rent surging at his longtime apartment, and he turned to his primary care practice for help. The on-site social worker was then able to help him apply for subsidized and income-based senior housing and other benefits that helped him when he was living on a fixed income, so that hopefully he could maintain his well-being and his health. And the second example that I'll give you is from our comprehensive ESRD care model, which is an ACO model aimed at improving the coordination and quality of care for Medicare beneficiaries living with end-stage renal disease. The model asks nephrologists and dialysis providers to work together to coordinate both dialysis and non-dialysis needs. So how did this impact patients in the model? Our evaluation actually included focus groups with beneficiaries that were receiving care under the model to see if they noticed changes in how they were experiencing the delivery and quality of their care. And we actually found that efforts to improve access to dialysis focus on preventing missed or shortened dialysis treatment sessions, because obviously when people are missing or shortening their treatment sessions, we see poorer outcomes. And the way that our providers in the model did this is by giving beneficiaries more choices about when to receive treatment. For instance, they added things like dialysis chairs and offered a late shift. And this flexibility was especially important for those beneficiaries who were working and juggling family needs as well. We also found that some providers reported improvements in the availability of transportation services in rural areas over time as ride-sharing services began serving smaller communities. And what we found was that missed treatments were significantly more likely to be rescheduled for model beneficiaries than in the comparison group. And then just some of the comments we received back from patients and providers, included that they found there was better communication from the care team, including more support for things like understanding medication changes. Providers reported more flexibility over patient care that allowed them to accommodate patients, for instance, as I talked about earlier, who couldn't make scheduled appointments. And they reported better continuity of care from home to the dialysis unit. So for instance, providing medication lists to patients as they were getting discharged. So these, I think, are some of the real ways that care can be changed and is changing on the ground for people and providers in our models. And I think these are the kinds of examples and the kinds of learnings that we need to continue to unearth and to dig in on so that we can really accelerate the movement to value-based and whole person care.
Thanks, Purva. That's great. As a reminder to the audience, we're going to open up the panel to Q&A shortly. So please put your questions at the bottom of your screen in the box anytime. And Emily, we're moving on to you. So Trinity Health is a large not-for-profit faith-based healthcare system. And earlier we talked about how VBC, value-based care, incentivizes care coordination, which benefits patients greatly. And Purva had some great examples of that. So how has Trinity Health prioritized coordination of care across the continuum? And what are some of the overall impacts you've seen for patients and healthcare spending?
Yeah, thanks so much, Judy. And so glad to be here to talk about our work at Trinity Health. It's very important to our mission to transform the health of the communities we serve, to move care from a sort of transactional setting to a whole person approach. And the change in the payment model provides the incentives to do that. So those are very aligned. For us, I would say all day, every day is about getting ahead of care needs. So it starts with the data we receive. We've already talked a little bit about the importance of the payer and other data sources. We can combine those with our own clinical data and get a much more complete picture of the population that we're accountable for to better understand their care needs, whether it's through patterns of care seeking or diagnoses that we capture that way and help us to identify people whose disease have multiple chronic disease that really need the extra support of the population health team. So that's it sort of starts with the data. And then for those people that we care for, particularly for those who do, to help them understand the disease that they are experiencing, to what strategies they could have to manage that better themselves. How do we make sure they have access to care in the community, in convenient places and at convenient times, so that we can prevent exacerbation of disease that might cause someone to need to seek care within the emergency room or hospital. Of course, when that happens, we want to be that exquisite site of care, but most of our work is to try and prevent that from happening. So really understanding the patient, understanding their care needs, and then having the team to intervene with whether it's self-management techniques, connection to the right specialists, or something like transportation. So we mentioned earlier some of the screening and the importance of screening, preventative care. Sometimes we might find reaching out to someone that it's lack of transportation that is the barrier. So being able to put that in place. So it's not always a medical need. Sometimes it is a community or health-related social need. So when we talk about the continuum, Judy, we really mean the full community. And then when somebody does need care with it in that acute setting, we do everything we can to get them back into the community, whether that takes a little extra work in making sure the home setting is safe for them, that they have services in home, or that they need another member of the care team to help when they leave the hospital so that they can stay healthy in the community.
Thanks, Emily. So we're now going to transition to taking questions from the audience. And again, one last reminder, pop it in the Q&A box down there. I think I'm going to start with a question about to date, the vast majority of value-based care programs have been focused on primary care providers or a very sort of discrete procedure-based episode of care like a knee or hip replacement. And there's not a lot of value-based care options for specialists managing chronic diseases. How are your organizations, or you sort of thinking about that, and how can we accelerate value-based care more into the specialist space?
So this is Emily. I'd be happy to take that because we very explicitly take a very broad approach to the network that we include in our alternate payment models, and we do a lot of that work. So 2 million people, $11.5 billion of total cost of care management. If you think about that LAN taxonomy that Andrea walked us through. Because we are looking to transform the health of the community, we include all the specialists. We include multiple access points. We try and bring in urgent care as much as we can in that community into the network. It does mean there's a lot more focus on connecting those points. So whether it's bringing the network together for a meet and greet between primary care and maybe a new specialist that is bringing some expanded capabilities to the network, or it's the folks who are going out in the community. We have quite a large community health worker workforce to make sure that our folks know what maybe new services, whether it's housing or transportation, that are available. So we take a very expansive view of network way beyond primary care because we want to have that broad impact.
Thanks. Maybe I'll just keep going. Oh,
I thought for sure that Perver was gonna jump in there because of CMS's work in the specialty area, and we're waiting for more in that area. But I would also say there's sort of the strategy of bringing specialists into the broader ACOs or accountable care or other buckets, right? And then there's also more of these sort of bundles where it's specifically targeted to individual specialists. It does, sort of back to that. Sometimes you have math problems that I mentioned earlier. If you think about, each plan only has a portion of a physician's book of business. And when you think about, how many of these enrollees have asthma, right? It's sort of like this funneling, and that you start to get to a little bit of difficulty from a administration perspective of kind of, do you have enough volume to make these work, and also just to administer them, right? If you're trying to do an asthma one, an orthopedic one, it's more difficult in that respect. But it's certainly something that the plans are grappling with every day and looking for different models, and certainly looking for multi-payer alignment that can get past some of these challenges with CMS.
Yeah, I'm happy to jump in quickly, Judy. We've actually have a pretty extensive 4-pronged specialty strategy, which I will not get into all the details here. But I think there are a lot of different ways that we are looking across all of our models. So not a single model, but really looking across the portfolio for how do we better engage specialty care. And, when we're thinking about accountable care and whole person care, I talked a little bit about HRSNs earlier, but that also means meeting not only people's primary care needs, but their specialty needs. And so this is a really core part of what we're trying to do, but it is complex. So one of the first things that we're really thinking about as part of that strategy, implementing ways to enhance specialty care performance transparency. So we really want to facilitate integration with advanced primary care practices, ACOs. There are data that we can provide to create those, high value relationships between primary care and specialty care. The second part of our strategy relates to acute episodic payment, which I think was referenced in that question, like how do we get beyond that? But it also includes condition-based models. So for instance, we have our new enhancing oncology model, or a follow-on oncology model. We also just announced a dementia model last year that's launching this year. So we know that there are areas in the specialty space where there are real gaps for beneficiaries and families. And so those are innovations that we can be testing. The third is creating financial incentives in primary care for specialist engagements, so things like co-management codes and other things like that, that again facilitate that integration and that connection. And then the last one is thinking about the incentives for specialists to affiliate in ACOs and accountable care organizations, and really thinking about, again, the delivery of that whole person integrated care. And that means moving upstream often and really thinking about co-management and thinking about longitudinal specialty care as well.
Excellent. So here's another interesting question, I think. What are some ways that individual providers can be involved in driving value-based care policies and initiatives at the community level?
I'm happy to jump in. We actually just launched a new value-based care spotlight page that includes a lot of information both for people like patients, but also providers about value-based care. I think it's an absolutely essential piece of what we need to make sure that when we are designing new value-based care programs, when we're trying to address health equity, we're trying to simplify the system, not only for our patients, but also the providers, that we're hearing from those voices on the ground. We routinely host listening sessions and engage with providers and experts from all over the country, and really welcome those voices to make sure that when we're designing a model, we're solving for the issues that providers are facing on the ground.
That sounds great. Just sort of a follow-up of individual providers. I think, on that hand, providers are like, how do I get this to happen more? But on the other hand, some people have experienced hesitancy in switching from a fee-for-service model to an APM. And how have any of your organizations kind of helped providers with those concerns about how do I pay my office staff? How do I make this switch if they change their model?
So this is Emily. I would say we try and do a lot of work behind the scenes to take the various models and come up with a simplified approach to pick up on Purvis their comment, so that when we are working with a practice, and we do a lot of work out, in those practices regularly, we are coming with a profile for how they can work differently with their patients with diabetes, not just, Medicare ACO or Medicare Advantage or Anthem or, but for their population. So we really strive hard to get as much of the practice into an alternative payment model, because then we can collate all that data and really look at the panel or the population that the provider is working with, and have the payer be more in the background. And I think, that sort of virtuous cycle, if you will, of more patients in these models, a more unified approach, is something that our teams do a lot of, to try and just, sort of reduce some of the friction when you get all these different messages and reports from different payers. So that's, I think, where once someone is part of one of our clinically integrated networks, they can participate in all the models, and that helps to really move more quickly. And then the people, we give them people in their practice to help with the work. And that is like, that's the thing I think that they think of the most probably is the name of that person that is in their practice, helping them with their most complex patients or helping them do some panel management and targeted outreach for preventative care, or care management.
I think the plans is sort of similar, slightly different flavor, right? And it depends on each of the plans. But of course, we try to highlight that there is, that there's data available, not necessarily, some organizations want massive amounts of claims data, right? But some, are like, all right, can you give me a dashboard? Can you have somebody go through this with me, that sort of thing. What Emily is also saying is that it's a blessing and a curse, because if every plan has a different dashboard, it's harder to manage. We're trying to work on that in terms of national interoperability policy, but it's going to take a hot minute to fix that one. But also, there are sometimes, depending on the plan, care management services. A lot of the plans are doing artificial intelligence applications on top of their claims to help identify patients who might benefit from additional services or where their conditions might decompensate soon, and really partnering with the physicians and giving them information, or, closing those care gaps, as we said, helping them to do that. And also work around, the community-based organizations, and sort of when you identify a health-related social need, right, that is sort of awful from a physician perspective. You ask the question, you identify a need, and what do I do about it now, right? There has to be something available. And so the partnership between the providers and the payers of sort of, learning like what's available in the community, how do we solve these sorts of problems together. So there's lots of different ways in which the plans and the providers are sort of partnering together to make these attractive models and make them work.
Thanks. There's starting to be a lot of questions, so I'm just going to keep them coming. So this is shifting a little bit to the maternal health population, and given the state of maternal health and some of the very poor outcomes we've seen, wider-based adoption of value-based care seems like a great solution. Why do you think we've seen such slow movement in this space?
And you said maternal
Health. Yeah.
I mean,
I'm thinking about, I think, like the health equity, especially in maternal spaces, and sort of how are providers not interested? Is there not models? Like, sort of, what's the gap we need to get to get to better maternal health outcomes?
Yeah, I mean, I mentioned earlier the Providence model. That's a maternal health model, that really helped reduce costs and improve quality. So there are out there, but I would also argue this is one of the areas where, if you think about these broader primary care-based ACOs, pregnancy is an everyday thing. You see, right? Like, it's something where there should be some integration within these models between the specialists and the primary care providers. But I do think, one thing, a particular area you mentioned, equity, Judy, is the maternal morbidity and mortality is much higher in this country than any of us would like to admit. And one thing that we at AHIP have seen is that when we want to stratify quality information, and Jen mentioned a little bit about this, you have to have standardized data on things like race, ethnicity, disability, other things, right? To cut that data so you can actually find the disparities. And right now, we're working on a major modernization project of demographic data factors and trying to put them into a national standard that will allow for interoperability so that we can share that information back and forth, right? Back when I said, oh, the plans have this data they want to give to providers. It's really hard right now. You got to send over a file, right? There's not a way for it to be built into the EHR. So there's this equity component where there's maternal morbidity or other things is, again, another nut that we're trying to crack, but there's a lot further to go on the journey.
Jennifer, you want to jump in?
Yeah. Yeah, I was just going to add, I do think that over the next couple of years, you will see more models implemented that are focused on maternal health. They may take an integrated care flavor. They may include providers like doulas who have not traditionally been included in value-based care models. So I can guarantee there's work underway, and I would venture to say you'll see them in practice over the next year or two. I will say near term, the severe maternal morbidity and mortality measures are being implemented at least into the quality dashboards that Blue plans are, some Blue plans are delivering to their providers, and then you'll start seeing them being implemented into value-based contracts as appropriate.
And Judy, I would just add, this is obviously, oh, sorry, go ahead.
I was going to say, I know you have a model, so you should talk about that.
It's always fun to get to talk about a new model, but this is maternal health and is a priority for the entire department and for our administrator, Chiquita Brooks-Lasher. And December 15th, we actually announced a new model, to your point, Jennifer, the Transforming Maternal Health Model. We're going to be releasing a notice of funding opportunity for state Medicaid agencies this spring, with applications due this summer. We're really excited. It's our newest model designed to focus on improving maternal health for people enrolled in Medicaid. Our goal is for the model to support state Medicaid agencies and the development of a whole person approach to pregnancy. Again, Jennifer, you sort of said there's lots of different dimensions of what pregnant people need. So all the way from pregnancy to childbirth and postpartum care, so that we're addressing physical, mental health, and social needs that are experienced during pregnancy. And the goal of the model is, at the end of the day, to reduce those disparities in access, treatment, and outcomes that I think we're all stunned by, and that we want to do something about. The model really aims, again, to improve outcomes, experience for mothers and their newborns. And the model really centers on three main pillars. One is access to care, infrastructure, and workforce capacity, which you all hinted at as well. The second is quality improvement and safety. And then the last is, again, that whole person care delivery, where we are paying attention to the full range of an individual's needs.
I think when I answered, I also answered specifically for maternity, but I think it's important to also point out that there's a lot of movement afoot, not just for pregnancy, right? But fertility leading up to menopause after, right? So trying to take a view of broader women's health within these models. Again, if you have a total cost of care model, it's all already in there, right? It's a matter of sort of finding the right, things to do, essentially, right? To improve that quality and reduce the costs. And of course, the experience, especially when you're thinking about menopause.
Yes. So one super quick question, last question for Jennifer and Danielle. Do you have any advice for purchasers to help encourage payers to pursue these types of models? And especially not just the like, oh yeah, we're doing it on paper, but really transform.
For purchasers?
Purchasers. So as you work with, companies, employers as a health plan, how do you help them, sort of move to these value-based care models?
Oh, go ahead, Jen. Oh, no. All right. So sorry, we're too polite. I think, obviously a lot of these models from the commercial perspective are with employer-based insurance. They are tailored to the particular employer and, their particular population, which could be geography, it could be, age and gender and other demographic factors, et cetera. So we take some of the lead from the employers. But, it is a partnership with the plans in setting these models up. And, I think the goals are the same, though, regardless, right? We're trying to improve quality, equity, affordability, patient experience, reduce burden across them. It's just a matter of, do you want a total cost of care model? Do you want some bundles model? Do you want a primary care model? And a lot of that has to do, again, with that sort of population and what's, who you're targeting, if you will.
Yes, there's I'm sorry to cut you off, Jennifer, but we are sadly out of time. And there are so many more good questions that we're just not going to get to. But I'd like to thank all of you for joining in this panel and thank the audience for attending. I think we had some really great conversation about this shift to more accountable care and using value-based care models and how that can really help people, patients and their families get better care and better health outcomes. I also think we've heard from a lot of you on the panel of senior healthcare leaders about some of the positive impacts that value-based care can really have. And if anyone's interested in learning more about accountable care, the LAN has resources on our webpage that include the APM measurement survey that was shared today, the accountable care curve, that's a tool to measure organizational progress towards comprehensive accountable care. The multi-payer alignment blueprint, which is a guide for applying engagement strategies to achieve multi-payer alignment. And then there's also some great resources on the CMS side, in particular, the new value-based care spotlight that Purva mentioned. So thank you all for coming today. Thanks for participating in Healthcare Value Week, and have a great rest of your day.